In 1998, at the heart of the historical and scenic city of Santo Tomas, Batangas, a medical center was established, which was initially conceived to provide healthcare services to the employees of its affiliate company, Yazaki Torres Manufacturing Incorporated, and other industrial clientele in the vicinity. The need for a modern, the fast-paced development of the Calabarzon region created a bigger demand and quickly expanded the client base for the medical center. This is St. Francis Cabrini Medical Center. It has served over 782,000 outpatients, 78,000 inpatients, and 284 corporate clients up to this day. St. Cabrini envisions to be the region's premier choice of patients, physicians, companies, and employees for their healthcare and wellness needs by offering a wide array of specialized services coupled with accurate result, reliable disease prevention, and effective medical treatment. Fostering a service culture enriched by continuous professional development, learning, teaching, and research. We believe that to be genuinely effective, care should be comprehensive. And we put our patients on center stage because we believe in our partnership to their journey to health.
Good morning. In behalf of the Anatomic Pathology section and the Cancer Institute, I would like to thank you all for joining us today in our webinar entitled Shifting Paradigms in Lung Cancer. During the course of this webinar, questions may be typed into the chat box or emailed. I will post the email address in the chat box. Lung cancer is the second most common cancer and the leading cause of deaths in both men and women. In the past decade alone, we have seen tremendous progress in the field of lung cancer diagnostics and management. To start off this morning's webinar, we have Dr. Rex Michael C. Santiago. Dr. Santiago is a graduate of the University of Santo Tomas College of Medicine and is a certified anatomic and clinical pathologist with subspecialty training in thoracic pulmonary pathology. He did his residency in anatomic and clinical pathology at St. Luke's Medical Center and was consistently among the top performing residents in the annual in-service examinations. He pursued further studies and did his clinical fellowship training in pulmonary pathology at the Toronto General Hospital, University Health Network under the University of Toronto in Toronto, Ontario, Canada. He did an additional month of observership in pulmonary pathology at the Memorial Sloan Kettering Cancer Center in New York. He has authored and co-authored several papers on thoracic diseases and has presented in conferences both locally and internationally. Dr. Santiago is currently affiliated with both St. Luke's Medical Center, Global City, and Quezon City as an anatomic pathologist. He is also currently serving as the head of the blood bank and transfusion services in St. Luke's Medical Center, Quezon City, and is the residency training officer in anatomic pathology of the hospital's Institute of Pathology. Additionally, he is also a visiting consultant in anatomic pathology at the Lung Center of the Philippines and in St. Francis Cabrini Medical Center.
Good afternoon, everyone, and thank you again for inviting me today to give this lecture on the shifting paradigms in lung cancer from the pathologist's perspective. So these are my disclosures. So lung cancer has seen a lot of advancements in recent years. Whereas before, we would only use our H&E slide to make a morphologic diagnosis. Now we also employ the use of immunohistochemistry for more definite histologic subtyping, as well as submit them for molecular testing so that we can potentially give targeted therapy to our patients. As such, this is kind of the outline of my talk. So first, we will move with a review of lung cancer morphology, and then this will be followed by the recommendations on the immunohistochemistry approach to subtyping non-small cell carcinoma. And then I will touch on about lung biomarker testing, and then a little bit about handling of small biopsies and cytology. So for the review of lung cancer morphology, so basically what we follow is the guidelines that the WHO has set for us, which they update every couple of years. So the most recent one for thoracic tumors is the fifth edition, the WHO classification of tumors, fifth edition, which was published just this year, actually, spring of this year. So this is the WHO thoracic tumors 2021. So basically for the WHO 2021, they retained a lot of the criteria and a lot of the tumors that were already present in the 2015 edition, save for some that I've highlighted here. For example, lymphoepithelioma-like carcinoma has now been changed to lymphoepithelial carcinoma, which is under squamous cell carcinoma. And then they also added in this new tumor known as thoracic SMARCA4 deficient undifferentiated tumor, as well as new papillomas, particularly bronchiole adenoma. However, I will not be discussing these as they are quite rare. So I will be focusing more on our usual non-small cell carcinomas, particularly adenocarcinoma and squamous cell carcinoma. So adenocarcinoma is basically a tumor that has glandular differentiation or mucin production. So it has been recognized that adenocarcinoma presents with several architectural patterns, at least the conventional adenocarcinomas. So particularly you have the lipidic pattern, which used to be called the bronchiolo-alveolar carcinoma, and I'll be touching more on this a little bit later on. And then you have the acinar adenocarcinoma, which is, of course, your more well-known, more classic adenocarcinoma that shows these irregular glands in myofibroblastic stroma. And then you have the papillary adenocarcinoma, where you have these tufts of tumor that has a central fibrovascular core. And then you have the micropapillary adenocarcinoma, where you have also tufts of tumor, but they tend to be detached from the surface and they do not have fibrovascular cores. And then you have the solid adenocarcinoma, which is basically an adenocarcinoma that does not show definite or obvious glandular differentiation or even mucin production. And these would typically require immunohistochemical stains to prove adenocarcinoma differentiation. Now, the thing is, ever since the 2015 edition of the WHO, they have required us to do comprehensive histologic subtyping, particularly on a resection specimen, so on your lobectomies or wedge resections. What basically this means is that you have to identify the predominant pattern and also the other patterns that are present, and you indicate them in 5% increments. For example, you have a papillary predominant adenocarcinoma with all of these patterns that are also present. Papillary, which is just 40%, acinar 20%, solid 20%, micropapillary 15%, and lipidic 5%. So this kind of accounts for the heterogeneity and the morphology of any given lung adenocarcinoma. The main reason why we want to do that is because it has been established in several studies. For example, this paper from Australia, where the predominant pattern actually kind of predicts the behavior of the tumor. So for example, you can see in the survival curve on the top graph here, you can see that the lipidic predominant tumors tend to have a well-differentiated behavior, whereas the acinar and papillary are in the middle and they have a moderately differentiated behavior. And here you have the solid line and the dashed line, which represents your micropapillary and solid adenocarcinomas, both of which are the most aggressive. So again, correlation of the patterns with the behavior. The well-differentiated tumors are the lipidic tumors. Moderately differentiated ones are the acinar papillary tumors, and the poorly differentiated tumors are those that have micropapillary and solid patterns. Now, I'd just like you guys to take note that the lipidic pattern is currently considered as a non-invasive pattern. So a little bit more detail about lipidic pattern is that formerly it was known as bronchiolo-alveolar carcinoma. And basically what it describes is that you have a localized adenocarcinoma with growth that is restricted to a neoplasm that grows along the pre-existing alveolar structures. So what basically that means is that when you look at this, it kind of still looks like normal alveoli or normal lung. So up here on your upper left, you can see what the normal lung looks like. And over here on the lower right, you can see what the tumor looks like. So they kind of have the same architecture, except that in the tumor, everything is just thicker, and the cells lining the stroma are atypical. So bronchoalveolar carcinoma is no longer recommended because they kind of found out that several tumors with different behaviors were all lumped together under this diagnosis. Particularly, we have these tumors that were all put together under bronchoalveolar carcinoma. So you have your atypical adenomatous hyperplasia, which is a small lipidic tumor that's less than 0.5 centimeters, adenocarcinoma in situ, which is larger than your AAH, but with a size cutoff of 3 centimeters. And then you have your minimally invasive adenocarcinoma, which is a lipidic predominant tumor that is less than 3 centimeters, but the invasive focus is less than 5 millimeters. And then you have the lipidic predominant adenocarcinomas, which are those tumors that have more than 5 millimeter invasion. Now, the thing about this is that with regards to behavior, AAH, AIS, and MIA all have very good prognosis, all have 100% disease-free survival with resection and free margins. Whereas, of course, your lipidic predominant adenocarcinomas, they tend to have a little bit more aggressive behavior, about 70% disease-free survival. So what it looks like on the slide is something like this. So you have a lipidic predominant tumor. So all of this is lipidic. And then where you have the yellow line is actually the invasive focus because it shows the acinar pattern. So in terms of invasion in lung carcinomas, it basically signifies that any pattern that is not lipidic is considered as an invasive pattern. So all of the other patterns that I mentioned earlier are considered as invasive patterns. On imaging, you can apply this because typically lipidic components of the tumor would appear as ground glass opacities or GGOs, whereas the invasive components are typically solid. Now, why this is important to know is because in the 8th edition of the AJCC staging manual, we actually need to use only the invasive component for our T category. So to give you a sort of visual explanation of that is that, for example, in this tumor, let's just say that this tumor is about 3 centimeters, predominantly lipidic with a little bit of invasion here, a little bit of acinar pattern here. Now, let's say, for example, that the acinar pattern is about 1 centimeters. So the total tumor size would be 3 centimeters, but the invasive tumor focus is only 1 centimeter. So this will be staged as PT1A based on only the invasive tumor size and not the entire tumor. So as you can see, it really impacts your staging. So moving on now, we have squamous cell carcinoma. Squamous cell carcinoma has basically seen fewer changes, so it's still defined as maybe perhaps how you remember it from medical school as these tumors that show keratinization, usually in the form of these whorls known as squamous pearls, as well as intercellular bridges. Sometimes you can get non-keratinizing squamous cell carcinomas, which are very difficult to differentiate from poorly differentiated or solid adenocarcinomas. And in these cases, you would require immunohistochemistry, which moves us to the next part of my talk, which is the immunohistochemistry approach in subtyping non-small cell carcinomas. So for non-small cell carcinomas, the immunohistochemistry, you can, at least for your typical straightforward cases, you can kind of divide them into two main categories. You have your pneumocytic markers as well as your squamous markers. So for your pneumocytic markers, you have TTF1 as well as napsin A. And then for your squamous markers, you have P40 and CK56. Historically, if maybe some of you have heard of this, P63 was used for squamous differentiation. However, this paper came out in 2018, I believe, which is the best practices for diagnostic immunohistochemistry in lung cancer. And this is a group of very well-known pulmonary pathologists. And they stopped recommending P63 for squamous differentiation because we now know that even in 20 to 30% of adenocarcinomas, they can express P63 staining diffusely. So it can be a pitfall. That's why they no longer suggest the use of P63 to confirm squamous differentiation. So why do we actually need to do all of these stains? Sure, for straightforward cases, perhaps you don't need to do stains. For example, if it shows definite glandular differentiation, such as this case on your left, then you can call it as adenocarcinoma. If it shows definite keratinization, then you can call it squamous cell carcinoma. However, and again, these cases may not actually need immunohistochemistry on a routine basis. However, the problem comes if you have something like this that's really poorly differentiated. There's no glandular differentiation, there's no keratin formation. So for these cases, definitely you would need to do IHCs. And they actually studied this in about 2014, where they tested the reproducibility of histopathologic diagnosis in poorly differentiated non-small cell carcinomas. And what they found out was that the agreement among these expert pathologists, if they looked at a specimen on H&E alone, for squamous cell carcinoma, there was only fair agreement. So the kappa score was only 0.36. For poorly differentiated adenocarcinomas or solid adenocarcinomas, it was also fair. However, if you can see here, if they added immunohistochemistry to classify these tumors, the kappa score improved significantly. So it became moderate for squamous cell carcinoma and substantial for poorly differentiated adenocarcinomas. And their conclusion was that with the use of additional stains, there was really improved reproducibility of histologic diagnosis for squamous cell carcinoma and adenocarcinoma. So you may ask us now, why do we actually need to be so meticulous with all of this subtyping? And to answer that, we will move to the third part of my talk, which is on lung biomarker testing. So it has been recognized for already a number of years that certain mutations are associated with lung cancer, and a lot of them are actually targetable. So this is the paper from 2015, and it shows you the relevant mutations in non-small cell carcinomas, particularly adenocarcinomas. And it's funny because if you look at this paper in 2017, you would see that the number of mutations has actually increased. And now in the WHO 2021, you would see here that for adenocarcinoma, the pie chart just became more and more granular. So over time, so many mutations are being discovered, and we all need to keep ourselves updated so that we can at least try our best to catch up. It's a good thing that they do come up with guidelines every few years. And actually, I think that this is due for an update, but this is a 2018 molecular testing guideline for the selection of lung cancer patients for treatment. And it's a collaboration between the College of American Pathologists, the IASLC, as well as the Association for Molecular Pathology. And this is a nice guideline to read on because it's kind of convenient since they divide the various molecular markers into those that are must test, should test and those that don't have any guidelines. So for those that are must test, which means that you have to perform them in every case of non-small cell carcinoma, at this point in time, they included EGFR, ALK, ROS1, and PDL1. Those that are considered as should test are those that you may actually think about doing if your must test markers are negative. So the reason you would want to do this is because, for example, you want to enroll them in a clinical trial. So you would maybe think about having these tests done. And at that point in time, these included HER2, MET, BRAF, KRAS, and RET. And those that had no guidelines yet were kind of the newer markers at that time. However, now it's 2021, and there are now so many more markers that are considered as must test, and I've highlighted them in yellow. Looking at it in another way, so here you have the must test biomarkers. In 2018, there was only four: EGFR, ALK, ROS1, and PDL1. And then in the latter part of 2018, BRAF became a marker that was among the must test category. And then in 2021 now, you have these 9 markers. Actually, you have 8 driver mutations here and plus PDL1. So EGFR, ALK, ROS1, BRAF, PDL1, MET, RET, NTRK, and KRAS. Possible markers in the future may include HER2, and the list just keeps on growing. So this is again from the WHO, and as you can see again, this is a nice pie chart, shows you a little bit of difference among the various ethnicities. So here you can see that for East Asian patients, we tend to have more EGFR mutations, whereas for those in Europe and the US, the EGFR mutations are fewer, about 5 to 15%. And most of theirs would be actually KRAS mutation. So we did look at this in our own institution. So this is a study that we published, or that my colleagues published, in the Philippine Journal of Pathology. And they also showed a similar finding in that the incidence or the frequency of EGFR mutation is about 49.4% in our population. So lastly, let's talk about handling of small biopsies and cytology material. And I think this is something that's a little bit more perhaps relevant for your practice. So as we all know, now tissue is almost always the issue. And the reason being is that as our equipment for getting or for acquiring tumor material becomes more advanced, we use smaller needles, therefore we get smaller and smaller biopsies. The number of tests are also concomitantly increasing. So there's kind of this tug of war that happens between the technology for acquiring the material as well as the number of tests that we have to perform. So just to show you in a more visual way, for example, you have a poorly differentiated non-small cell carcinoma, then you would have to do your IHCs for subclassification, whether it's NSCC, NOS, if all are negative, adenocarcinoma, or squamous cell carcinoma. And then you would have to do your biomarkers. So for squamous cell carcinoma, usually it's a lot simpler because you only have to do PDL1 in most cases, unless the patient has clinical features of a patient who has a driver mutation, particularly if it's female, young, never or light smoker, and East Asian patient. Whereas for adenocarcinoma and those that you would end up calling as NSCC, NOS, you have to do all of the markers that I mentioned. And these are usually performed on different platforms. For example, EGFR and BRAF, and most of the other markers are performed through molecular testing that are usually PCR-based or next-generation sequencing. ALK and ROS1 can be done by fluorescence in situ hybridization, or FISH, and then ALK, ROS1, and PDL1 can be done by immunohistochemistry. So as you can see, in a given case, you need material for H&E, for immunohistochemistry, as well as for your molecular or biomarker testing. And as you can imagine, that consumes a lot of tissue. So from the pathology point of view, What are the possible reasons for an inadequate biopsy? Now, we all know that this is a common situation that we encounter in our daily practice, where we send material and then it comes back to us as inadequate. So, from the pathologist's point of view, what are the possible reasons for this? So, one situation is when we produce too many smears and there's not enough tissues in the cell block specimen. So, the problem here is that we can't really do immunohistochemistry and molecular testing on cytology smears. We can only do them on cell block specimen and on core biopsies. So, for example, if you have something like this, we can possibly give you a diagnosis of carcinoma, but because there's not enough material for further testing, particularly for biomarker testing, then there's a possibility that we would still need to do a repeat biopsy. So the second situation is if there's only a few viable tumor cells. So just for you guys to get a better idea, let me just show you a brief overview of the workflow in histopathology lab. So for example, when we get a specimen, we place them in these containers called cassettes, which undergo overnight processing and then are embedded in paraffin. Now, these cassettes are subsequently placed in a microtome where they are cut into very thin sections to produce these ribbons. The ribbons are placed on a water bath and then they are fished out on a slide to produce these good quality slides that we look at on the microscope. Now, before I move on, let me just highlight the concept of rough cuts. So rough cut is when the histotechnologist places the cassette on the microtome and then cuts through the tissue until he can produce a surface that is even before he can actually make the slide. And this would ensure that the quality of the slides are really good with very thin sections, thin and even sections. So ideally, this is kind of the workflow that we want to happen. So basically, once you have the cassette on the microtome, you want to already produce all the slides that you would need for H&E staining, for IHC, as well as for molecular testing. So everything is cut up front. So what happens in the Philippines is something more like this. So for example, we have a case, and then first we produce slides for H&E diagnosis where we come up with sort of like a preliminary diagnosis, request for IHCs, and then we would have to call the attending physician, call the patient, whether they want to proceed, and then we produce another set of slides for IHC. And then after that, once we have the definite histologic subtype, we would suggest molecular testing and then produce another set. Now, the problem with this is that with every time you interrupt this process, so example, here you remove the cassette from the microtome after doing your H&E, and if you return it on the microtome for the IHC staining, you have to do another set of rough cuts because the angle will be different. So as you can imagine, with each and every process here in between, you would have to do rough cuts, which consumes more and more tissue. So the problem with this sort of algorithm is that generally there's a longer turnaround time, as well as it consumes a lot more tissue. So just to show you, this is what ideally an adequate biopsy would look like. So you can see it is a very fat core that has a lot of tumor material. And this would definitely be adequate for all of the tests that I mentioned. Unfortunately, we can get material like this. So this is an actual case that I handled during the early part of my practice, where the interventional radiologist actually argued with me. So basically, I said that the material that was given was kind of suboptimal in cellularity. And he argued that he actually submitted a lot of specimen, which is kind of true because he did submit like 2 bottles of specimen. But the problem is, as you can see here, there's only a small amount of tumor. And you would see here that this is the only fragment that actually is cellular. And even in that cellular fragment, only the areas where the arrows are, you would find the tumor. The rest is just inflammatory cells as well as stromal cells. Now, if you look at that specimen on lower power, you would see that it's really mostly blood. So this specimen is actually suboptimal, and you would probably not be able to do all of the tests that I mentioned, the IHCs as well as the biomarkers. And eventually that patient actually needed a rebiopsy. So the third problem is when pathologists ask for too many stains. Of course, this is now our problem. In the WHO, even in the previous editions of WHO, particularly the 2015 edition, but also in the 2021 edition, they do give recommendations on how to approach biopsies so that you can maximize the tissue that is present for IHCs and molecular testing. So this is sort of like their recommended terminologies. So for most cases of non-small cell carcinoma, or most straightforward cases, you would only need a limited number of stains. So TTF1, absent A, which are your pneumocytic markers, and P40 and CK56, which are your squamous markers. And actually, if you want to even limit that even more, you only need TTF1 and P40 for most cases. However, of course, there are still some situations where we actually need more stains. For example, if it's not a non-small cell carcinoma, for example, this one has the morphology of small cell carcinoma, then we have to confirm it. We have to do all of these things, CK, TTF1, our neuroendocrine markers, chromogranins, synaptophysin, INSM1, CD56, and our proliferation marker, Ki67. Or for example, if we're thinking of a pleomorphic or sarcomatoid carcinoma, then we have to prove epithelial differentiation or use TTF1 absent AP40 as well. So there are situations that we would need to do more stains than we would like, but in most scenarios, like I said, TTF1 and P40 would suffice. So before we leave or before I end my lecture, let me just show you a couple of interesting cases. So this is sample case 1. It's a 70-year-old patient who has a lung mass, and these are actual cases, by the way, who is a non-smoker. So this is his biopsy, and as you can see, it's a poorly differentiated tumor, so it's a non-small cell carcinoma. We did our IHCs, it was all negative. So we ended up, if you follow the sort of algorithm, so it's a non-small cell carcinoma. There's no definite glandular or squamous differentiation. All our stains are negative. So we ended up calling it as NSCC-NOS, and we sent the material for driver mutation testing and PD-L1. So I ended up calling this as non-small cell carcinoma, not otherwise specified, and suggested biomarker testing. Now, I also added this comment in, while findings may be compatible with a primary lung malignancy, other primary sites should be ruled out clinically. And of course, the reason why I did that is because this is a tumor that was negative for all the markers. As such, there should be clinical correlation to make sure that this is a primary lung tumor. So when we did molecular testing, the patient had a BRAF mutation, and there's a targeted therapy for BRAF, which the patient actually had, and he had good response for about a year. And then after that, there was progression. So when they studied the imaging again, at this point, they found a colonic mass. So now the question is that colonic mass related to the lung mass, or is that like sort of a double primary? So when we did our tests, our IHCs, it turns out that the lung mass was actually a metastatic colon carcinoma. And interestingly enough, when they reviewed the imaging from before, there was already some thickening in the colon. So the thing that I just like to highlight here is the importance of clinical and imaging correlation, because although a lung tumor can be negative for all the markers, you still have to make sure that the tumor is actually a primary lung tumor and there's no other tumors in other sites that we should be worrying about. So another case, sample case 2, this is a 64-year-old male. He has a history of adenocarcinoma from 2 years prior. This was positive for EGFR mutation, particularly exon 19 deletion. Now, he was treated with a second generation TKI, afatinib, and was stable for about 18 months, but subsequently developed progression, which manifested as an increase in the size and number of pulmonary nodules. So they did a biopsy of these nodules, and what came out was this tumor, which is actually a small cell carcinoma. So, of course, that's kind of weird. Are you wondering, is that like a new primary? Is that a new tumor? But actually, this is a typical case of histologic transformation to small cell carcinoma. And we did publish this as well in the Philippine Journal of Pathology. So histologic transformation in an EGFR mutant lung cancer treated with afatinib. And as far as we know, this is the first published case for histologic transformation on TKI therapy. So basically, I just like to highlight that immunohistochemical stains and molecular studies can have their own pitfalls in sensitivity and specificity. While it is necessary to preserve tissue for molecular testing, clinical history always plays an important role, particularly in the choice of IHCs. And of course, the patient's treatment history is now important, particularly in the assessment of lesions on progression. Finally, and I'd like to highlight this, multidisciplinary approach to lung cancer is really, really paramount and important to ensure the best outcomes for our patients. And this is endorsed by the IASLC if you look at this paper from 2011. So in summary, determining the definite histologic subtype with the help of IHCs and molecular studies plays more importance now due to specific treatment protocols. The number of targetable mutations continues to grow and is rapidly growing. Hence, we need to continuously keep ourselves updated. Tissue is the issue. It is imperative that we follow best practices in the acquisition, handling, and processing of the tissues in order to perform all the necessary testing. And finally, a multidisciplinary approach to lung cancer is necessary in providing the best possible care for our lung cancer patients.
Thank you, Dr. Santiago, for that very thorough and informative lecture. Our next speaker is Dr. Ana Karina de Lara. Dr. de Lara is a graduate of a Doctor of Medicine in the University of Santo Tomas. She had her internal medicine residency at the National Kidney and Transplant Institute, followed by a medical oncology fellowship from the same institution. She is a fellow of the Philippine Society of Medical Oncology and is a member of the Molecular Oncology Society of the Philippines. She is presently the head of the Cancer Institute of St. Francis Cabrini Medical Center.
Good morning, everyone. I am Dr. Ana Karina de Lara. Thank you for the opportunity to discuss lung cancer in 2021, testing, targets, and treatments. Today, I would talk about the impact of precision medicine in lung cancer treatments and outcomes. I would go over the current treatment algorithm for patients with non-small cell lung carcinoma, and then move on with discussing the emerging and exciting data for early stage lung cancers and unresectable stage 3 lung cancers. Then we will talk a little bit about the current management in small cell lung cancer, which we know is managed differently from non-small cell lung cancers. And lastly, we will try to discuss the challenges of precision medicine in 2021. Traditionally, non-small cell lung cancers have been classified according to histological features. Currently, we have a tremendous amount of knowledge about driver mutations in non-small cell lung cancer that has evolved over the past 20 to 30 years, starting with the discovery of the KRAS mutations in 1987 to the discovery of the EGFR mutation in 2004. And now, in 2021, there's a complex array of biomarkers that we test for in our patients with non-small cell lung cancer. So it has been a long journey for lung cancer. This is sort of an overview at how we've progressed over time. We've gone a long way from just picking any doublet chemotherapy with a median overall survival of around 6 to 8 months to having precision medicine a reality around 2009 onwards. The treatment paradigms for advanced non-small cell lung cancer patients have evolved through two major routes. First, molecular targeted therapies based on different driver oncogenes in cancer cells, and second, immune checkpoint inhibitors such as monoclonal antibodies against programmed death ligand 1 and programmed death 1 receptor that reverses the immunosuppressive effects elicited by tumor cells. Laboratory testing to identify those likely to respond to such targeted therapy based upon a predictive biomarker represents a paradigm shift in lung cancer diagnosis and has now become a standard of care. Pathologic diagnosis of lung cancer is now a multi-step process, beginning with morphological diagnosis to determine the histological type, refined by immunohistochemistry where required, followed by appropriate molecular characterization of the tumor. So why are biomarkers so important? I think this figure here illustrates very well that we see a lot of targetable mutations in non-small cell lung cancer, and we have a lot of drugs available for almost each target. Not all of them are FDA approved yet or available in the Philippines, but they are in clinical trials. So there's a lot of opportunities to offer patients with advanced lung cancer these days. What is the promise of lung cancer precision medicine in 2021? A very nice paper by Hollander published in New England Journal of Medicine from 2020 has showed that the implementation of targeted therapies and novel immunotherapies has improved survival outcomes for patients with non-small cell lung cancer. And indeed, we've seen targeted therapies and immunotherapy transform the care of patients with metastatic lung cancer. We've gone from a median survival of only 6 to 8 months with chemotherapy alone to improved 5-year survival with targeted therapies. Immunotherapy has also led to improved outcomes and longer survival in a broader subset of patients without oncogenic driver mutations. A number of factors come into play when choosing the appropriate targeted therapy in advanced non-small cell lung cancer. In addition to patient preferences and comorbidities, we first have to ask, do we have an actionable genomic target? And do we have the correct biomarker for identifying that target in terms of gene mutation, expression, fusion, amplification, deletion, or etc.? Do we know what the best drug is to use in terms of efficacy, tolerability, and CNS penetration? And when multiple treatment options are available for any given subtype of lung cancer, do we know how to optimally sequence these therapies? Presented here is the current treatment paradigm for genomic alteration positive advanced non-small cell lung cancer. In 2021, we have 8 known genomic alterations in lung cancer that are actionable. But as of today, the only drugs that are available in the Philippines are those highlighted inside the yellow boxes. And for this reason, our biomarker testing in the Philippines is mainly centered into looking into EGFR, ALK, ROS1, and PDL1 testing. For patients with metastatic non-squamous non-small cell lung cancer, the NCCN panel currently recommends that the minimum of the following biomarkers should be tested, including PDL1 expressions, EGFR mutations, ALK fusions, ROS1 fusions, BRAF, MET exon 14 skipping mutations, and RET rearrangement. But in the Philippines, our biomarker testing is mainly centered on testing for PDL1, EGFR, ALK, and ROS1 since they are the genomic targets with currently available drug in the country as of today. The guidelines would actually strongly advise broader molecular profiling with the goal of identifying rare driver mutations like HER2, KRAS, and NTRK, for which effective drugs may be already available in other countries, or to appropriately counsel patients regarding the availability of clinical trials. For squamous cell lung cancer, the minimum necessary is testing for PDL1 expression. Testing for oncogenic driver mutation is not usually recommended in patients who appear to have squamous cell carcinoma unless they are former light or never smokers, if only a small biopsy specimen was used to assess histology, or if the histology is mixed like an adenosquamous type. Let's now focus on EGFR mutations. It is known that the incidence of the driver mutations in lung adenocarcinoma is different between Caucasians and East Asians. While KRAS mutation is most common in Caucasians, EGFR mutation is the leading driver oncogene in East Asians. And in particular, the frequency of EGFR mutation in patients with lung adenocarcinoma in the Philippines is around 52%. The most common activating EGFR mutations sensitive to EGFR TKIs are deletions in exon 19 in 40% of patients and a point mutation in exon 21, L858R in about 40%, comprising approximately 80 to 85% of all activating EGFR mutations. These mutations result in the activation of the tyrosine kinase domain, and both are associated with sensitivity to the small molecule EGFR TKIs. Less common mutations account for 10 to 20% of all EGFR mutations, and they show variable responses to currently approved EGFR TKIs. These EGFR mutations are also prognostic, as some EGFR mutations like the exon 20 insertions having poorer prognosis as compared to other mutations and are less likely to respond to currently available targeted therapies. Thus, the need to identify specifically which type of EGFR mutation the patient has, and this is a big factor in choosing which targeted therapy to choose for a particular patient. First generation TKIs, gefitinib and erlotinib, and the second generation afatinib and dacomitinib have been found to be superior to chemotherapy for treatment of patients with common EGFR mutations, as demonstrated by a longer median progression-free survivals. In the FLORA trial, the third generation TKI osimertinib has demonstrated a longer progression-free survival as compared to either erlotinib or gefitinib, 18.9 months versus 10.2 months. The median duration of response was also longer, with a median response time of 17.2 months versus 8.5 months. An updated analysis showed that the median overall survival was a very impressive 38.6 months with osimertinib compared to 31.8 months for either erlotinib or gefitinib. So in this slide, you see the current first-line treatment landscape for EGFR-positive non-small cell lung cancer. This is a description of the trial, but it is not a head-to-head comparison. So we see osimertinib in the first-line setting has resulted in impressive PFS and OS as discussed previously. Docomitinib, not currently prescribed here in the Philippines, also showed an improved progression-free survival and overall survival. Afatinib in the LUX-Lung 7 trial showed an overall survival benefit of 27.9 months versus 24.5 months as compared to gefitinib. And we have these two trials wherein erlotinib is combined with angiogenesis inhibitor, and it also resulted in improved progression-free survival. The importance is that all of these treatment regimens have different toxicity profile, so it is important to consider this when deciding which drug you prescribe in the first-line treatment for a patient. Despite initial response to EGFR TKIs, most cases develop acquired resistance to each of these drugs. A point mutation in exon 20 T790M is the mechanism of acquired resistance in more than 50% of these patients progressing from first-line erlotinib, gefitinib, and afatinib. Osimertinib, the third-generation EGFR TKI, was developed to overcome T790M resistance. The mechanism of resistance to first-line osimertinib are different from those in first and second generation EGFR TKIs. It is revealed from FLORA trial that MET amplification was the most common resistance mechanism, followed by secondary EGFR mutation, PIK3CA mutations, and HER2 amplification. Ongoing trials are now in the process of looking into how we can overcome resistance to these mechanisms. This figure summarizes the treatment algorithm for stage 4 lung carcinoma with EGFR mutations. First-line therapy includes first, second, and third generation TKIs, as well as combination of erlotinib with anti-angiogenic inhibitors. Upon progression, patients with oligoprogression can be offered local treatment and continue the current targeted systemic treatment. And in patients with multiple systemic progression with clinical evidence of EGFR TKI resistance but not previously treated with osimertinib, patients should be tested for the presence of an EGFR exon 20 T790M mutation. Liquid biopsy or circulating free DNA plasma testing can be used as the initial test for the detection of a T790M mutation. And if tests are negative, a rebiopsy should be attempted if feasible. Osimertinib is the standard therapy for patients whose tumors have tested positive for T790M mutations, while platinum-based doublet is the standard therapy for patients whose tumor is tested T790M negative. We are still awaiting the final data on the different trials trying to answer how to overcome acquired resistance to osimertinib. These are all already presented in the recent ASCO convention last June. Again, it is important to identify the mechanism of systemic disease progression. We can target bypass mechanism. We can target histological transformation. We can also in the future target C797S mutation by using new combinations like antibody drug conjugates, which could target all of this mechanism of resistance or even unknown mechanism of resistance in clinical trials. Moving on, how do we treat advanced non-small cell lung cancer patients if they're all negative for actionable oncogenic driver mutations? Let's discuss the role of immunotherapy and chemotherapy in this subset of patients. One of the major advances that have been achieved in the field of non-small cell lung cancer is by targeting two very important inhibitory immune synapses, namely the interaction of CTLA4 and B7 in the priming phase of the immune response, and the interaction of PD1 and PDL1 in the effective phase of the immune response. In non-small cell lung cancer, we had the opportunity to be exposed to many inhibitors of these two very important steps for immune activation: ipilimumab and tremelimumab as anti-CTLA4, semiplimab, nivolumab, pembrolizumab as anti-PD1, atezolizumab, avelumab, and durvalumab as anti-PD1 in the context of clinical trials or even routine practice. This has led to these impressive key milestones in the recent years, where many of these drugs have been registered in advanced non-small cell lung cancer and also recently in locally advanced early stage non-small cell lung cancer. So how can we better select patients for immunotherapy? In non-small cell lung cancer, we have mainly been using two different biomarkers: the expression of PDL1 as measured by immunohistochemistry, and the surrogate of the presence of a neoantigen as measured or calculated by tumor mutational burden or defined by the presence of microsatellite instability. We also have been looking at surrogates of immune response by characterizing and quantifying immune infiltrates or by trying to define immune gene signatures, which, by the way, have not really reached clinical application. PDL1 currently is the only validated, although an inconsistent marker for immunotherapy selection. One reason for this inconsistency lies in the various antibodies used for immunohistochemical staining. There are currently at least 5 commercially available assays for PDL1 staining, and each of these assays were developed with different scoring systems and for different drugs, thus creating complexity in ordering of the test and interpretation of results. PDL1 represents a biological continuum of biomarker expression, leading to the conclusion that depending on the expression and level of expression, you are speaking about the likelihood of response to the strategy in our cancer patients. Asking ourselves the question of how do we define positivity? Would we prefer to work with intervals or with cutoffs? And where do we set this cutoff if we have to fix them? Despite the variability in assays and heterogeneous expression, PDL1 expression remains a fair predictor of single-agent immunotherapy benefit. In contrast to single-agent immunotherapy, PDL1 expression has not been shown to be a robust predictor of chemoimmunotherapy. Thus, in clinical practice, PDL1 expression may help direct clinicians between immunotherapy or chemoimmunotherapy, where single-agent immunotherapy is preferentially chosen for patients with high PDL1 positive tumors, while chemoimmunotherapy for lower PDL1 expressions. Immunotherapy is truly a game changer in advanced non-small cell lung cancer without oncogenic driver mutations, as it continues to demonstrate a significant overall survival benefit. Pembrolizumab and atezolizumab were FDA approved also in patients with PDL1 more than 1%. In patients with high PD-L1 expression of more than 50%, pembrolizumab in the KEYNOTE-024 trial gave a very impressive median overall survival of 30 months as compared to 14.2 months for standard chemotherapy, telling us that those with higher PD-L1 expressions respond better to those who have lower PD-L1 expressions. As a combination approach, a number of chemoimmunotherapy combinations and doublet immunotherapy combinations proved to be superior to chemotherapy, regardless of PD-L1 expression. Again, this is not a head-to-head comparison of the clinical trials, and this is presented only for descriptive purposes. And now I present to you the current standard of care for the first-line treatment of patients with non-small cell lung cancer whose tumors do not harbor targetable oncogenic drivers. This consists of immunotherapy-only regimens and chemoimmunotherapy combinations for patients with tumor PD-L1 scores of 50% or higher. And for those with PD-L1 score of less than 1%, immunotherapy combination represents the standard of care. A combination of two immunotherapies like nivolumab and ipilimumab may be considered for patients with TMB high or for those who are poor chemotherapy candidates. And specifically among patients with tumor PD-L1 score of 1 to 49, who comprise about a third of patients with advanced non-small cell lung cancer, chemoimmunotherapy and immunotherapy-only regimens also represent accepted standards of care. Upon progression, we can consider doing repeating biomarker testing as above, using ctDNA or rebiopsy of tumor sample to determine mechanism of resistance and maybe identify any targetable mutation. And with the recent advances in the treatment of metastatic lung cancer, today we are now looking into moving up these therapies for early stage and locally advanced settings. And here I'm gonna present to you two of the recent practice-changing trials for lung cancer. It has long been established that stage on initial diagnosis is a major determinant of survival from lung cancer, and with patients who present with disease that's amenable to curative intent approaches having the most favorable outcomes. And still, among patients who undergo surgery with curative intent, 5-year survival hovers around 50%. We can improve survival by about 5% with perioperative chemotherapy, but that's modest. Let's first discuss the existing strategies. So for adjuvant therapy, the sequence typically consists of surgery followed by 4 cycles of platinum doublet chemotherapy, and in recent months, select subset of patients with sensitizing EGFR mutations who are eligible to receive an EGFR TKI. And that is the ADORA trial that I will discuss in the next few slides. As far as neoadjuvant approaches, this typically consists of chemotherapy plus minus radiation and concludes with surgery. ADORA is a phase 3 double-blind randomized study assessing the efficacy and safety of osimertinib versus placebo in patients with stage 1B to 3A EGFR mutant non-small cell lung cancer after complete tumor resection and adjuvant chemotherapy when indicated. Patients were randomized into 1:1 fashion to osimertinib 80 mg once daily or placebo to receive treatment for up to 3 years and stratified by stage, mutation type, type, and race. Primary endpoint is disease-free survival, and secondary endpoints were overall survival and safety. The primary endpoint in ADORA was met, with osimertinib demonstrating superior disease-free survival versus placebo in patients with stage 2 to 3A disease, and an impressive hazard ratio of 0.17, equating to an 83% reduction in the risk of disease recurrence or death with osimertinib. This was a highly statistically significant result with a p-value of less than 0.001. The disease-free survival benefit with osimertinib was consistently seen across all three specified patient subgroups, with impressive hazard ratios ranging from 0.12 to 0.50, and a clear clinical benefit apparent regardless of the stage, EGFR mutation, or race. The ADORA trial concluded that adjuvant osimertinib will provide a highly effective, practice-changing treatment for patients with stage 1B, 2, 3A, EGFR mutant non-small cell lung cancer after complete tumor resection, and testing for EGFR mutation status in completely resected early-stage cancers may be a new standard of care. In the phase 3 Pacific study of patients with unresectable stage 3 non-small cell lung cancer without progression after chemoradiotherapy, patients were stratified after chemoradiation to durvalumab for 1 year versus placebo. The primary endpoints were overall survival and progression-free survival in the intent to treat population. As of January 11, 2021, with a median follow-up duration of 34.2 months in all patients, the 60-month overall survival rates were 42.9 and 33.4 with durvalumab and placebo respectively, and the 60-month progression-free survival rates were 33.1 and 19% respectively. These updated results, based on the 5-year data from the Pacific trial, demonstrate robust and sustained overall survival plus durable progression-free survival benefit with the Pacific regimen. This establishes a new benchmark for the standard of care in the unresectable stage 3 non-small cell lung cancer setting. The Pacific regimen is being investigated in combination with different chemoradiotherapy regimens as well as with other agents following chemoradiotherapy. There are still many unmet needs in the treatment of localized lung cancer, and there are many trials that are now looking towards giving adjuvant and neoadjuvant therapies in the early stage setting. Let's start with phase 3 studies exploring adjuvant checkpoint inhibitors. There are 4 study designs summarized here, each one comparing immunotherapy versus the standard of care, and we are still eagerly awaiting results from most of the studies. We're still awaiting most of the results of the studies dealing with neoadjuvant or preoperative immunotherapy, but we know that this approach is safe and feasible. I do want to mention that there are also neoadjuvant studies exploring targeted therapies. Another study design that's being explored is asking the question of whether or not we can replace the standard of care chemotherapy with targeted therapy. So we don't have outcomes yet for the ALINA trial, but we did learn from EVAN and adjuvant trial that disease-free survival was improved with the targeted approach over chemotherapy. Aside from the ADORA trial discussed earlier, there's also an ongoing Alchemist study for EGFR and ALK positive lung cancer that is exploring basically a similar study design. Let's now move on to talking about small cell lung cancer. Are we beginning to impact outcomes in this subgroup of patients? We've seen incredible progress in terms of the number of new drugs available for patients with non-small cell lung cancer, and increasingly, this have allowed us to personalize treatment for patients. In small cell lung cancer, though, the gains have been more modest. We know that small cell lung cancer is the most aggressive form of lung cancer, and that the majority of patients will have advanced metastatic disease at the time of their diagnosis. Although small cell lung cancer is usually very sensitive to chemotherapy and to radiation initially, it often relapses within a few months of starting initial frontline therapy. And currently, there are no approved targeted therapies or biomarkers to guide treatment. This is a table that was presented last year at ASCO, and it really highlights the fact that we do have a new standard of care in the frontline setting for extensive stage small cell lung cancer patients. And this is the addition of immune checkpoint blockade together with platinum etoposide chemotherapy. This is based on several studies shown here, and I'm going to highlight two: the IMpower 133 trial, where atezolizumab was added to platinum etoposide, and the Caspian trial that added durvalumab. Both of these randomized phase 3 trials led to the FDA approval based on about a 2-month improvement in overall survival with the addition of immune checkpoint blockade. Recently, there's been longer follow-up that's been published for these studies and presented at recent conferences. I'm showing here the updated findings from the IMpower 133 trial. After about 2 years of median follow-up, we can see that the improvement in survival is maintaining at the 18-month landmark. 34% of patients in the arm receiving the addition of atezolizumab are alive as compared to 21% in the chemotherapy control arm. One thing that's been notable in this trial is that biomarkers such as TMB and PDL1 that predict immunotherapy benefit in non-small cell lung cancer have not demonstrated utility in small cell lung cancer. So at the moment, we are still in a one-size-fits-all kind of treatment approach where patients who are diagnosed with extensive stage small cell lung cancer are really receiving a single standard of care in terms of the addition of immunotherapy together with chemotherapy. And unlike non-small cell lung cancer, we unfortunately don't have actionable driver mutations in this space as well. So there's definitely an urgent need for new approaches to be able to personalize treatment for these patients. What are the challenges of lung cancer precision medicine in 2021? Some barriers limiting access to biomarker testing includes tumor limitations, quantity of the tumors not sufficient to get molecular profiling. Hopefully, liquid or plasma biopsy will make biomarker testing more easily accessible. Second is provider education. Keeping up with all of these new targets and new drugs is not necessarily straightforward, and understanding the types of biomarker testing, what they can and cannot test for, is also not straightforward. And it's going to get increasingly complicated with more mutations, immune markers, and germline assessment. We also have patient access issues, especially true here in the Philippines, where, when, and how care is delivered, and we have known issues and trust in the healthcare system, and of course, cost considerations. I would like to discuss this local paper by Dr. Lance Catedral and the PGH Medical Oncology Group published last 2020 by ASCO. The study described real-world biomarker testing practices among medical oncologists in the Philippines in the management of breast, colorectal, and lung cancers, the top three malignancies in the country. In addition, the study also aimed to identify the driving factors and barriers to biomarker use in the study. A total of 127 respondents participated in the study. For lung cancer, given the current cost of biomarker testing, only 67.72% tested for EGFR routinely. Only 27.56% would order for PDL1. And of note, 55.2 and 44.8 of the respondents had never used BRAF and ROS1 respectively in real-world practice. Guideline recommendation was the most frequent motivation for biomarker testing. This mirrored the results of a similar survey of oncologists from other countries. Of note, almost half reported using biomarker tests because their patients were included in clinical trials. In terms of barrier, almost all the respondents indicated that they would not pursue biomarker testing if their patients reported financial difficulties. Other reasons include patient preference, unavailability of the test in the area of practice, and this is especially true in provinces far from Metro Manila, where most of the molecular laboratories are located. Cited reasons also include insufficient sample size, specifically when the specimen is from a tissue FNAB or pleural fluid cytology. One of the barriers also is the long turnaround time, since the test would come out after about 1 to 3 weeks for tissue biopsy and even longer for plasma NGS. Given these findings, we can conclude that biomarker testing is still not universally applied in actual clinical practice among medical oncologists, and there are many barriers for biomarker use in the Philippine setting. And if we don't test, we don't allow for proper drug access. In summary, biomarker testing for non-small cell lung cancer is important for identification of potentially efficacious targeted therapies, as well as avoidance of therapies unlikely to provide clinical benefit. Major developments have been made in the treatment of advanced non-small cell lung cancer with and without driver mutations, as well as in the early stage and locally advanced stage. But there continues to be an unmet need in this area. Lung cancer precision medicine is promising with the advancement of biomarker testing and new drug development, but its challenges still remain, especially in equitable access to testing and use of novel drugs. And with that, I would like to end this presentation. Thank you for your kind attention.
Thank you for attending this morning's webinar. For any questions that you may have, kindly email to anatomical.lab.sfcmc@gmail.com. Again, thank you and have a pleasant day ahead.